Hello students, I hope you guys are doing well. For today, we are going to discuss anemia, its types, and medications to correct it. Basically, anemia is a lack of hemoglobin, which is a blood protein made up of 2 alpha chains of 141 amino acid residues, each, and 2 beta chains of 146 amino acid residues each, and is proportional to the oxygen-carrying ability of the red blood cell. It means hemoglobin, HGB or HB, is the primary carrier of oxygen in humans, and 1 molecule of oxygen can bind to the iron atom of a heme group, giving each hemoglobin the ability to transport 4 oxygen molecules. So, higher hemoglobin levels contribute to an increase in the blood's oxygen-carrying capacity. The etiology of anemia is the low hemoglobin level that diagnosis anemia results from 2 different mechanisms: an increased hemoglobin loss due to either a hemorrhage, red blood cell loss, or a hemolysis, red blood cell destruction. Second mechanism, a reduced hemoglobin synthesis due to either a lack of nutrient or bone marrow failure. Non-specific signs and symptoms associated with anemia are tiredness, fatigue, dyspnea, that is feeling short of breath, faintness, headache, pallor, including conjunctival pallor. Before this diagram of some of the stages within erythropoiesis, we have to know what erythropoiesis is. So, erythropoiesis is your body's process of making red blood cells, erythrocytes. Firstly, erythropoiesis starts from the pluripotent hemopoietic stem. For more clear explanation, here is the video of formation of RBCs. It starts in the bone marrow with the pluripotent hematopoietic stem cell. Some of these cells will differentiate into the erythroid lineage, which after a few steps result in a large blue cell with a high nucleus to cytoplasm ratio called a proerythroblast. Unfortunately, as with many things in medicine, there is not uniform terminology here. So sometimes these cells are referred to as pro-normoblasts. And some dogmatic hematopathologists might say that they aren't exactly synonyms, but they're close enough for everyone else. As the maturation process continues, the proerythroblast predictably becomes an erythroblast, also known as a normoblast, which is a smaller cell, has a grayer cytoplasm, and a relatively smaller nucleus. The erythroblast stage is subdivided into basophilic, polychromatophilic, and orthochromatic stages. Most notably, the general erythroblast stage is when hemoglobin synthesis starts, which is partially responsible for the shift in the color of the cytoplasm. Eventually, the erythroblast will lose its nucleus and some organelles, forming a reticulocyte, which looks kind of like a mature red cell, but are slightly larger and slightly bluer. Reticulocytes initially retain ribosomes, meaning that they are still capable of limited protein synthesis, such as synthesizing some more of the cell's hemoglobin. In normal circumstances, a reticulocyte, more commonly known as a retic, spends about 3 days in the marrow before entering the systemic circulation, where they will take about 1 more day to fully mature, losing their remaining organelles and becoming an erythrocyte. The normal lifespan of an erythrocyte is about 120 days. Therefore, in healthy adults, about 1% of circulating RBCs are retics. There are various different tests that are performed to check anemia, like 1. Full blood count, 2. The mean corpuscular volume, MCV, test reflects the average size of the red blood cell. It is beneficial and indicates microcytic, low MCV, normocytic, MCV in range, or macrocytic anemia, high MCV. 3. Ferritin test. Ferritin is an iron-containing protein in the blood. 4. Blood smear test that is categorized by size. It is useful if there is more than 1 type of anemia present. 5. Liver function tests, renal function tests, thyroid function tests. Now moving to the types of anemia and their treatment. Iron deficiency anemia. Iron is present in the body at 50 milligrams per kilogram, of which 760% is in RBCs, 30% in body stores, as ferritin and hemosiderin, 5% in muscle cell myoglobin, and 5% in various enzymes or bound to transferring. A low HB does not necessarily mean low iron, and a full blood count, as well as iron studies, should be conducted to determine whether it is iron deficiency anemia, and so iron supplements are required. It can be treated with 200 mg ferrous sulfate tablets twice or 3 times daily if tolerated. It is important for the pharmacist to counsel patients on gastrointestinal effects and that their stools may appear black as a sign of working of medication, and they have to continue with the medicine. HB should be by 1 to 2 grams/liter every day and continued for 3 months after normalization of HB to replenish iron stores. Sideroblastic anemia. It is described as a group of anemias which are characterized by the presence of abnormal erythroblasts, called ring sideroblasts, in the bone marrow aspirate. Normal erythroblasts contain some iron granules. Sideroblasts are defective erythroblasts which contain an excess of iron granules in the mitochondrion. The treatment is pyridoxine therapy, usually 200 to 600 mg orally daily. In hereditary forms, management will depend on its severity and could include blood transfusions for the most severely affected patients. Remember, iron deficiency is not associated with sideroblastic anemia. Ferritin levels are usually raised in sideroblastic anemia, so avoid use or iron. Vitamin B12 deficiency. Anemia. It is also called pernicious anemia. Vitamin B12 is found in meat and dairy products but not in plants. Signs and symptoms include general symptoms of anemia: a glossitis, a angular chylosis, peripheral neuropathy. Medication for this type is with parenteral vitamin B12, hydroxycobalamin, initially alternate day injections for 2 weeks to replenish stores, and then every 3 months. Oral maintenance with cyanocobalamin is an option only if the deficiency is due to diet alone. Folate deficiency anemia. Folate is found in most foods, especially green vegetables, but it can be destroyed by cooking. Causes of folate deficiency include dietary deficiency and malabsorption, increased requirements, e.g. pregnancy, increased losses, e.g. malignancy, other causes, e.g. prematurity, folate antagonist drugs. Medications are: treatment is with folic acid 5 mg daily, and patients should be encouraged to increase dietary intake. Coexisting vitamin B12 deficiency should be corrected. Folate deficiency in pregnancy can lead to neural tube defects. Women who are pregnant or planning a pregnancy should be advised to take folate supplements. If 400 micrograms daily before conception and for the first 12 weeks gestation. A 5 mg daily in women with diabetes or sickle cell disease, or on anticonvulsants. Follow for more informative content.